Hello, welcome to Ask the Pearl. This is episode 5, and this is Dr. Rick Rosenfield. I am Nick Fogelson, and we're going to be talking about incontinence today.
Yes, we are. And we can start out by, first of all, clarifying that we're speaking of urinary incontinence because there's different types of incontinence. And the idea of incontinence would be losing urine when you don't want to lose urine. So,
right, Rick. I mean, this is a common problem that people come to see us with, and it's a problem that women are not always very comfortable talking about, and they really should be comfortable talking about it with a gynecologist because it's really what we're aware of. We're really expert in that area, in addition to urologists being expert in that area. And in fact, female incontinence is an area that all OBGYNs are trained in, and then some go on to do a specialized training. And while Dr. Rosenfield and I didn't do fellowships in urogynecology, we have a lot of experience in this area, and we're really enjoyed taking care of women for this problem and have a lot of success with it.
yeah, I think the interesting developments in this particular space has been the tendency for us to try to seek less invasive operations as a specialty. And since we've both been doing minimally invasive gynecology for so long, it was a natural progression for us to get into this. The other thing is when you look at the number of patients affected by incontinence, and you look at the different types, which we're going to get into momentarily, but nearly 50% of patients in the U.S., female patients, are going to be afflicted, 1 in 2 people, by some form of incontinence during their lifetime. So this is a really significant issue that we need to deal with.
Right. There's really 2 reasons why women get incontinent over the course of their life. And some women, of course, won't get incontinent, unfortunately, but some do develop incontinence of urine, and then sometimes also kind of sub-incontinence, where they don't necessarily leak, but they feel like they're about to leak, and it bothers them. Even though they're able to go to the bathroom and not leak, it's something that bothers their life. And those 2 things are, you can think about them as being structural versus functional. And so we have one thing called urge incontinence, and that's really a functional issue where the bladder just doesn't know how to hold its urine anymore. And it's really an age-related change, and it's a neurologic change in the bladder.
And those are definitely the types of incontinence that most people are familiar with because they're oftentimes treated with medication. So you're going to see TV ads where you have a woman either running off the golf course or she's trying to get out of the jury box because she feels this overwhelming need to use the restroom. And the description that we hear from patients is that oftentimes they'll lose the entire contents of their bladder because this is really a scenario where the bladder, which is really a muscle surrounding urine, which is fairly toxic to other parts of the body if it's not protected in the bladder. So the urine can create a spasm in the bladder, and that spasm can actually lead to incontinence.
Right, and it's very much like when you're a baby. When you're young, you don't know how to hold your urine, and that's something that your parents teach you. And we actually, it's funny, we think our parents teach you, but the truth is that as we develop neurologically, we develop the neurologic ability to hold our urine. And when we're babies, we suddenly have a spasm in our bladder and we pee. And then as we get older, we learn how to hold it. And then eventually, of course, we're societally trained and neurologically developed to where we can hold our urine for a long time. Interestingly, as you get older, you start to lose some of that neurologic development in the same way that you had when you were a baby. And sometimes your bladder just develops a spasm when it's full of urine, and you get this feeling like you have to go, and you either run to the bathroom and make it, or you don't make it, and that's when you have urge incontinence. Now, if you have that feeling that you have to go, but you make it to the bathroom, we call that urgency. It's really the same thing. It's just the question is how far are you from the bathroom when it happens, and how severe is it? So that problem is actually something that can be treated with, in some cases, with medication, and it can also be treated with physiotherapy in some cases, can be helpful. And then there's another thing called bladder training, which is a lot like the way you train a baby how to not urinate, where you tell them to go to the bathroom on a frequent basis. You can actually do that as an adult, and you can train your bladder to not leak. And those are things that we work with on patients all the time when they have this kind of problem.
Also dietary modifications. There's also alternative and naturopathic solutions too, and we try to really be holistic with our approach. We don't want to perform surgery unless it's necessary. We always want to make sure we're doing the appropriate testing on our patients to figure out what type of incontinence a patient has, because one of the biggest reasons why incontinence treatments don't work is the clinician makes an assumption that they know what the problem is without doing the proper diagnostic testing. If that happens, they can start going down a pathway where they're treating the wrong condition. We see this sometimes when our primary care associates and maybe don't have the training that we do, and when there's a structural problem, they prescribe a medication that would be used for an irritant problem, and that doesn't lead to a solution. So we see a lot of folks that come in and think that they haven't been able to get proper treatment, or that they don't respond well to medicine, when in fact the problem is structural, which maybe we can go into that.
Yeah, and conversely, if somebody has an urgency problem and you do a surgery to kind of fix something structural with the bladder, it can make it worse.
Absolutely.
So it's really important to understand that. So the other kind of incontinence is what we call stress incontinence, and that is the classic incontinence where you jump or you sneeze or you dance or you laugh and you leak.
Right. So if you can imagine that my arm here is a urethra, okay, and urine would be coming out of my fingers and the bladder would be my body. Very interesting way of, we could probably draw a diagram, but this is great. So typically when a patient coughs, the urethra's got really good support, right? After having babies, sometimes the urethra will drop down like this, and you sometimes can even see this structural change when we do an exam as a gynecology surgeon. When that happens, there's no backstop for the urethra to bounce against, and what ends up happening is the pressure in the bladder with a cough or sneeze causes amounts of urine to come out, and that's what stress incontinence is all about.
Exactly. I mean, the way I was taught at a little more technical level is that the bladder and the urethra was supposed to be up in the abdomen. And so when you cough or sneeze, you push on the bladder, but you also push on the urethra. It's kind of like a turkey baster, and you're pushing on the bulb of the turkey baster, but you're pushing on the end of it too. So all the pressure's the same. But when you lose the support for the bladder and the urethra, now it falls out of the pelvis almost in the vagina. And so now if you cough, you push on the bulb of the turkey baster, but that pressure is not being transmitted to the urethra. And so effectively, it's like squeezing the turkey baster, and of course the urine just shoots right out.
Right.
So all of the surgery techniques, of which there are a bunch of different techniques for dealing with this, they're all about bringing the urethra and the bladder back up into the abdomen where they started when you were younger, before they became damaged.
Right. Or taking that urethra and putting a backstop underneath it, so when it comes down, it hits something like this. And
right.
That way, when it hits that backstop, you don't leak urine.
Right. And these techniques are really quite effective. I mean, we have patients that leak every day, and we do fairly simple surgeries. They can go home from the same day, and they are really happy. They just never leak again. And they really work great. I mean, we have many patients that are just really happy because it's a big problem in their life.
We're also really, really fortunate in Portland that some of the leading experts in pelvic floor physical therapy have, for some reason, either chosen to train or live in Portland. So we've got some wonderful physical therapists that will actually do internal exams on our patients. It's a really big deal for physical therapists to be familiar with the pelvic floor muscles, because then they can work with our patients to help them with bladder control and strengthening.
Mm-hmm. Yeah, and sometimes incontinence, stress incontinence also coincides with prolapse, which is something else that we're going to talk about in another video, where there's actual, because the bladder is falling down, you may also have some lack of support in the rectum and even lack of support in the uterus itself, or if the uterus is gone, in the cuff of the vagina. And sometimes surgeries are required to repair all these things at once. And often people that have some lack of support in the bladder also have problems in these other areas. But why do they happen, Rick? Like, why are people developing this problem?
Which problem? We're talking about
why do we lose support?
Well, losing support is almost always due to pregnancy and childbirth.
Right.
Typically if you're pushing out a large baby head through the vagina, you're going to potentially stretch some of the ligaments that actually support the vagina. The vagina has walls that have muscle inside of them, and at the top of the vagina, where the vagina and the cervix meet, there's actually ligaments that attach at what we call the pubocervical ring that maintain pelvic floor support. It's complex stuff. We can always review diagrams with our patients to explain these things, but the simple way to think of it is that the pelvic floor is much like a trampoline with springs around the outside that are attached to a framework. And there's, at the center of that trampoline, imagine an inner tube, and that would be sort of the cervix. And when a baby passes through that area, there can be a lot of trauma to that area, and the bladder's nearby, which can impact a woman's ability to urinate. So
there's a number of risk factors for developing problems. One would be that having vaginal birth is a risk factor. Having cesarean sections are somewhat but not completely protective, because just the weight of carrying a baby for 9 months can damage the pelvic floor, even if you deliver the baby by cesarean. Another thing is that if you have operative deliveries with forceps, and somewhat less so with vacuum, that is associated with a higher likelihood of issues. And also, if there are significant tears to the pelvic floor during delivery, A lot of people, when they deliver babies, will tear a part of the back of the vagina, and usually the obstetrician will repair that after delivery. But you can also imagine that there are structures inside the vagina and in this whole pelvic floor support system that may tear or stretch, and you don't see it. In fact, sometimes people deliver a baby and the vagina is completely intact and it's not torn, but there may be things inside that have torn or stretched. And when you're young and you have really good muscle tone, it may not affect you. So you may have your babies in the 20s or early 30s and sometimes later, and you may not have a problem, but then as you get older in your late 40s or 50s, the damage that was done when you were younger can then present itself more significantly. And that's sort of where pelvic floor physiotherapy becomes important as well, because the damage was done when you were younger, but you didn't have a problem because there was a lot of good muscle tone there. And as you get older and the muscle tone isn't quite as strong, then that damage becomes more important in the function of the bladder, the function of the rectum, and everything like that. And so one of the ways of treating it is potentially to exercise and improve the tone of the pelvic floor. That's done with pelvic floor physiotherapists if you really want to do it right. And a lot of people can do really well with that, but it's kind of like working out. Some people want to work out and go to a personal trainer and learn how to repair their pelvic floor, and some people would just rather have us fix it with a surgery. And you can do it either way, but definitely different patients have different goals.
Yeah, one last topic that we probably ought to speak of, and this is a lot of information, but I think that there's, most folks that have watched any late night television have probably seen an ad that has either criticized or brought attention to the use of polypropylene mesh, mainly used for pelvic floor reconstructive operations. And patients get very confused when they see these ads that there's a problem. Mm-hmm. And the suburethral slings that we put in are almost always made of this polypropylene mesh. However, the problems that we are seeing with polypropylene mesh when placed in for pelvic prolapse is different than for incontinence, although all of these things were sort of looped together in a recent class action lawsuit. So I would encourage you to speak with your physician about it because it's a very important topic. Yeah. But one thing to know is that the slings that we put in, these polypropylene mesh slings, they can be removed. So if there is a problem, these things are removable. The pieces of mesh that were problematic were bigger pieces of mesh used for prolapse corrections that were very difficult to remove from the patient and creating very, very significant long-term problems. These are items that we will be talking about in our next episode a little bit more in depth, I would imagine. Mm-hmm. But definitely important just to bring attention to it because one of the things that we do a lot of is the surgical correction of urinary incontinence. In the next episode also, just a little teaser, we'll be talking about some non-surgical office-based remedies for both mild to moderate prolapse, which we'll be talking about, as well as the incontinence stuff. Mm-hmm.
Yeah. So if you have further questions, make sure you put them in the comments. We can talk about them in future episodes. And thanks for watching Ask the Pearl. I'm Nick Fogelson.
Rick Rosenfield.
And we are at the Pearl Women's Center in Portland, Oregon. If you have questions, send them to us. And if you'd like to see us for clinical consultation, we would love to see you. Thanks for watching.